So where there's a will, there's a way, right? That was fantastic. We look forward to learning more about that. Dr. Sardo-Malmente is one of my colleagues from Northwell. She has spent her entire career focused on colorectal cancer research. She's had many extremely original ideas that she's brought to fruition, publication, and grant support. But today she's going to talk to us about her very innovative efforts around advanced adenomas. And Christine probably wouldn't mention it, but she really has spearheaded this effort. She's led the roundtable effort to look at this issue. So we're really very fortunate to have her here today to help us understand the significance of advanced colorectal polyps and how we can use that information to save more lives. Christine?
Thank you very much for that kind introduction, Tom. And thank you, Tom and Cindy, for the introduction and invitation to speak at this year's summit. I must say that I was at the first young onset or early onset colorectal cancer summit. This is my fifth time, and the survivor stories that we heard this morning, when I hear those, they are so powerful, and every time it feels like the first time I've ever heard those stories, but I've heard them for 5 years. And as a person that's been very interested and motivated to understand the etiology of young onset colorectal cancer and what are some of these causal drivers, I find it most significant that so many survivors stand up and say they were fit, healthy. In previous summits, we hear people say, a lot of the loved ones of unfortunate survivors and some people who succumbed to the disease, that they ran a marathon 3 months before they were diagnosed. And so I find a lot of the data that we're looking at and some of the inciting factors that we're interested in, not only looking at the things that we think are things people are adding to their diet, things are obesity, but what are the things that some of these young, fit people are missing? Because I find the phenotype of this young onset colorectal cancer patient to be very interesting. They don't fit the typical physical sort of characteristics and some of the things we're so used to talking about. So what I'm interested in and what I'm going to be talking about today is another area that's relatively understudied. We don't know the prevalence of these polyps and advanced polyps among close relatives of young onset colorectal cancer. So I really encourage everyone, and I always, think about it myself, is to find new ways of thinking about this disease and really pick up clues that survivors are telling us that are resonating over and over again in these forums. So today what I'm talking about are advanced polyps. And this, again, like I said, is an area that we don't fully know about. And the reason that polyps are so significant is because polyps are the precursor to the majority of colorectal cancer. And they progress through the adenoma to carcinoma sequence, which is the traditional adenoma, or through the serrated pathway, the sessile serrated adenoma and traditional serrated adenoma. And this is typically a slow-growing tumor. Normally, from the time of initiation of a cell until you see a visible growth, it's 15 to 20 years. And for a carcinoma to a metastatic tumor, it's substantially less, about 2 to 3 years. And it's because there's multiple environmental and genetic exposures, in addition to multiple epigenetic alterations that are driving adenoma development and colorectal cancer development. What we don't know is that are there biological differences between a young person, like the person on your left, who is diagnosed with colorectal cancer at 31, or like Dr. Barakat's family member, 24? Do they follow the same timing and sequence of the established adenoma to carcinoma sequence that we've all studied for years? And so this is a big question. But we do suspect that advanced polyps do play a very significant role when there's a familial component. And so not all polyps are created equal. Like I was saying, there's 2 different pathways. The serrated polyps are typically your hyperplastic polyps that are benign, very small. You'll hear people who have colonoscopies, when they complete the procedure, you ask them what happened, and they say, I had a polyp removed. And that's the typical response, but people don't know what type of polyp was removed. And for such a screening procedure that is so powerful, that has the potential to prevent the majority of colorectal cancer, and people leave that procedure telling their friends and relatives and whoever that they had a polyp removed, really does a disservice to what we're trying to accomplish with colorectal cancer prevention. And this is even heightened in young onset colorectal cancer, because this information could be life-saving for a lot of people. So those are the serrated lesions. Then there's the conventional adenomas, which they're fairly prevalent. By the time someone is 60, 30 to 40% of the population will develop an adenoma by the time they're 60. And if you've had an adenoma, the chance of it recurring is up to 50%. And really, the severity of these polyps is really determined by the size of polyp that was removed, how many were removed, and what the histological features were. And what I've been working on with the National Colorectal Cancer Roundtable and our Advanced Adenoma Working Group, in addition to the study I'm going to talk about today through Fight CRC, is a way to condense the information about polyps. And we've come up with 3 main categories that really distill the information on size, number, and histology. So anyone that has a tubular adenoma that's greater than 1 centimeter, or a sessile serrated polyp greater than 1 centimeter, so the size, 1 centimeter automatically puts that polyp into an advanced category. Any dysplasia or villus features also put that polyp into an advanced category. When we look at the risk factors for both of these types of polyps, they're very similar to risk factors for colorectal cancer. And the final one are traditional sessile adenomas. Regardless of the size, if someone is diagnosed with this type of polyp, it is an advanced polyp. There are guidelines that have been developed for patients with advanced polyps, and actually any polyp. So if you have a colonoscopy and you've had one of those hyperplastic polyps or a small adenoma that's not advanced, your surveillance time is anywhere from 10 years, 5 to 10 years, or if you have multiple adenomas removed or polyps removed over 3 in number, your surveillance is also earlier. But the bottom line is any advanced polyp, the patient needs to come back at 3 years for early surveillance. The problem in today's world is that a major public health problem is the under and overuse of colonoscopy. We don't see a problem with people with small adenomas and hyperplastic polyps coming back in 5 years or 3 years. That's way overused, and people don't need to come back at that interval. Where we do see a problem is with advanced polyp patients not coming back or adhering to colonoscopy at 3 years or less. And importantly, for the first-degree relatives of advanced polyp patients, there's a specific implication. Number one, first-degree relatives, meaning parents, siblings, and children of any patient diagnosed with an advanced polyp, is at an increased risk for advanced polyps themselves and colorectal cancer. And we're talking about an up to 6-fold risk of advanced polyps and up to 4-fold risk of developing colorectal cancer. This is regardless of the age that the advanced polyp was found. This information is not communicated to family members. In addition, if a lot of people in the room may recognize that these are the same recommendations that we see if someone is diagnosed with colorectal cancer. And here are the specific guidelines for first-degree relatives of patients with advanced polyps. The follow-up is colonoscopy every 5 years, beginning 10 years before the age of diagnosis or age 40, whichever is earlier. These are USMSTF guidelines and the NCCN guidelines. And again, it's really regardless of age. And this information is a specific component of the follow-up after colonoscopy that is not used today. So one of our key initiatives from the Advanced Adenoma Working Group with the National Colorectal Cancer Roundtable was to develop a GI brief. And we developed and distilled a lot of this information down for GIs in primary care. In fact, it's going to be launched hopefully in the next week or two, and we'll disseminate it to everybody in this room. But the whole purpose of this brief is to take all of the guidelines, all of the epidemiology, all of the background information, and bring it down to a very simple, engaging way for providers to understand and, most importantly, communicate to their patients. We have 3 objectives, really to remind providers of the implications for their patients and family members with advanced polyps, also to keep providers up to date with the current guidelines, and we also provide template letters that, through Dr. Paul Schroy's work, have been have been tested and found to be effective in risk communication. And so there are 3 sections to the brief. The first section really is to make sure GIs and primary care understand the epidemiology, the prevalence, the burden of disease with advanced polyps, what the definition of an advanced polyp is. The brief has a number of very simple boxes, an easy way for people to understand what these definitions are. Even primary care and GIs, a lot of them can't answer the question, how do you define an advanced polyp? Finding advanced polyps has implications for both patients and family members, and then the template letters. Like I said, it's a simple brief. We've distilled the information, but the most important part of this brief that we hope gets out to providers is the fact that there are implications for patients' first-degree relatives when someone is diagnosed with an advanced polyp. And again, the interval is starting at 40 or 10 years before the youngest affected relative. The template letters that we've created will all be online. Just yesterday, we were downloading the macros into our EMR at Northwell to see if we can use them and readily access them. These are all preformed letters that providers can put into their EMR, that they can adapt with the patient information and any other information. They can share with the patient as an educational tool. The patient can share them with their family members. And it's really closing the loop between GI and patient as risk communication. And primary care, for that matter, if it gets to them as well. But the real knowledge gap is what percentage of young onset colorectal cancer is due to family history of advanced polyps. And most recently, Dr. Dennis Anand and Heather Hampel, through the Family History Task Force and conversations, really spearheaded this question. And so I got involved in really providing the clinical infrastructure and the manpower behind getting a lot of this study implemented. And I'll show you what we're planning to do. But this was just awarded at the end of last year. We're almost approved to begin recruitment. This is a priority area in young onset colorectal cancer research because it will contribute to this component that was unknown with family history. And it will be the first study of its kind to really investigate this question. This is a unique cohort. This is part of the Ohio Colorectal Cancer Prevention Initiative, which Heather Hampel is the PI. Patients were recruited across the state of Ohio between 2013 and 2016. They were all diagnosed with a primary invasive colorectal adenocarcinoma. And in our specific cohort, there were 709 patients diagnosed under 50. And then once the patients with the cancer susceptibility gene or a family history of colorectal cancer were removed, we're left with 492 patients in our cohort who are otherwise considered sporadic. And you would have seen this in Dr. Anand's talk as well. And so what we're really looking at here is, what is this 14%? We think it's at least 14%, but it could be more. It could be 20%. It could be 30%. What is the prevalence of advanced polyps in young onset colorectal cancer patients' relatives? And that's what we're hoping to find. And maybe we can squeeze that bit of the pie that's less unknown in terms of sporadic causes, and maybe more of it is family history. And so this is a feasibility study design that we were funded for. They wanted to first make sure that we could actually contact these patients. And so this is a very brief overview of what the study looks like. Our step 1 is to contact the young onset colorectal cancer patients from Heather's cohort at Ohio State. And we want to enroll 50 patients into our study. Once we enroll those patients, we're going to contact all of their FDRs. And we think there will be 4 at least FDRs per patient, or on average 4. And once we contact all the first-degree relatives, we're going to ask them if they've had a colonoscopy prior to their relative's diagnosis of young onset colorectal cancer. Then we're going to ask them if they remember what the results of their colonoscopy were. And then we're going to ask them for their facility information of that colonoscopy, and we're going to collect all their medical records. And we're going to verify, first of all, did they recall correctly what they had removed? And secondly, for the purposes of the study, just document that an advanced polyp was actually removed in those patients. And so in each step, we have a specific study team that is working to recruit these patients. Because this is a very sensitive topic and a very sensitive area, there are a number of these patients that are currently deceased. So we're going to be contacting their next of kin or emergency contacts. And so we really believe that OSU is the best first line of recruitment, because these patients were recruited through Ohio, they know Ohio State, And so we'll be sending all these recruitment letters through Northwell, but the Ohio State team will be following up with them. Once we get all the FDR information for those probands, then our team will pick up and contact all the FDRs, collect all the colonoscopy facility information, and that piece of the study. Again, it's a pretty extensive recruitment effort. We have online recruitment, we have letters, everything is set up through REDCap. And then we have, at Northwell, recruited a team of colorectal cancer surgeons, GI residents, and surgery residents who are going to be the ones calling the colonoscopy facility, asking for the medical records and verifying the pathology. And so what we're really doing in this feasibility stage of the study is really understanding what is the recruitment rate of probands? How many probands do we need to call to enroll 50? Secondly, what is the recruitment rate of FTRs? Are we able to get a complete family for each of these probands? And how many of those FDRs actually decide to participate in our study? Again, this is a very sensitive topic. Rate of medical record verification. Are these colonoscopy facilities reachable? Can we get the records? Can we verify the pathology? And then we have a number of secondary feasibility aims which relate to the average length of time. How long does it take us from start to finish for one patient to go straight from the proband to the records? Accuracy of colonoscopy results. We want this so that when we do a larger study, we can say there's an 80% accuracy rate that people understand their results, which I don't think it's going to be that high. And then the reasons that people either refuse participation. And so this is our research team at the Feinstein Institute for Medical Research at Northwell Health and at The Ohio State University. We have our colorectal surgeons there. These are our surgery residents that are going to be making calls to all the facilities. We have all of our administrative support in the middle of the slide there who are helping us to set up the entire infrastructure of the study. And then our FIGHT CRC team, for anyone that isn't familiar with the FIGHT Colorectal Cancer Foundation, they are one of the leading colorectal cancer advocacy groups. They support advocates, they support scientific research, and it's a real honor to be funded and working collaboratively with them. So our action plan, if we can recruit 50 probands and find that this is feasible, we already have funding somewhat in line to do a larger study that will be powered to accurately estimate the prevalence of advanced polyps in this larger 492 cohort. We need about 185 of those probands to enroll. We are now just at Northwell, just last week, we had a study IRB approved to recruit and enroll, which we've started already, patients who've had colonoscopies and have had advanced polyps. And we're going to be asking them if they've spoken to their family members, how can we help them speak to their family members, hoping to work with the family history toolkit that we can actually bring into the primary care setting as well. And then finally, we are planning a widespread dissemination of the National Colorectal Cancer GI Brief. I have a sign-up sheet here, which we're going to pass around during the lunch. For anyone that has ideas, if you're going to a conference, you're going to a meeting, you're involved with an organization where we can email this brief to a list of GI's primary care to get the word out would be extremely appreciated. And following up from this meeting, once the brief is launched, we'll email it to everybody on the email list. So in summary, diagnosis of advanced colorectal polyps have implications for patients and their first-degree relatives. The prevalence of advanced polyps among young-onset colorectal cancer patients is being investigated and has major clinical implications for increasing awareness among GIs and primary care. And then the NCCRTI brief not only provides a resource of information, but shareable data and letters that can help to improve risk communication following colonoscopy. I wanted to acknowledge the entire Advanced Adenoma Working Group to the National Colorectal Cancer Roundtable. This group was formed about a year ago. This was our major initiative for this year, and could not have done it without the collaborative effort, especially my co-chair, Jordan Karlitz, and Jennifer Kolb, and Dennis and Paul, who are always outstanding, and they never give up on another revision. So it's been a pleasure to work with everybody, and it's a real quality product that we've produced. And then my support at the Feinstein Institute. Thank you very much.